Now, we know from the membership that SGLT2 inhibitors are a subject of great interest, and I'm delighted to have three people who've been running the session this morning, one speaker and the session heads. Welcome. Andreas Birkenfeld from Germany, Chantal Mathieu, who's well known, I think, to all of you, and finally, Kristine Faerch from Denmark. So let me turn first of all to you, Chantal. What were the main takeaways for you from this session?
We tried to make a session that was focused on SGLT2, but it was obvious that there were actually two sessions in this one session, one on SGLT2 or SGLT1/2 inhibitors in type 1 diabetes, and then the very interesting topic of SGLT2 inhibitors in type 2, exploring more the effect on complications and also the effect in pre-diabetes. But the enthusiasm, and I'm a bit partial, was enormous on type 1 diabetes. That's really where the novelty is, and people are eager to use that. And it's just an illustration of the unmet need that we have in type 1 diabetes.
Andreas, take that on for us. Tell us about its use in type 1.
Yes. So in type 1, it was shown that the SGLT2 inhibitors do have beneficial effects in glucose lowering and also on body weight. And I think this was very interesting to see that body fat is actually reduced, and that it's not only the diuretic effect that reduces body weight. So I think that was really an interesting, intriguing result.
Christina, tell us a bit about your presentation.
Yeah, so we did a study in people with pre-diabetes defined on the basis of HbA1c, where we compared dapagliflozin, metformin, and exercise. And we found a reduction in glycemic variability in those receiving dapagliflozin and also in those exercising. And for all interventions, we found improvement in HbA1c and also in all other glycemic parameters.
Andreas, what should the average diabetologist in clinics around the country and around the globe, what should they take away from this session?
I think they should take away that SGLT2 inhibition is a novel beneficial option also on patients with type 2 diabetes and type 1 diabetes, yet they have to remember that there's a certain risk of DKA, and of course they have to explain patients how to use SGLT2 inhibitors, when maybe not to use them, and how to check for diabetic ketoacidosis. But overall, I think it's really important to now think about which patient can we also put on an SGLT2 inhibitor with type 1 diabetes.
Chantal, anything to add?
Yes, first of all, the fact that we do have regulatory approval for two agents, dapagliflozin at 5 milligrams and sotagliflozin in individuals with a BMI above 27 kilogram per square meter. So we do already have some regulatory guidance which patients would probably have the best risk-benefit ratio. Benefit was listed, hemoglobin A1c, more time in range, less body weight, less insulin dose, and the price to pay, the genital infections and the small added risk of DKA. And as was said, education of medical teams and of patients will be crucial to use these agents safely in type 1.
And where next in research on this area?
Yeah, we need more longer-term studies because the effects we observed here after 13 weeks of treatment was rather small. But maybe the potential for improvement using SGLT2 inhibitors is there. So we need more studies, and also in other pre-diabetic subgroups than the one we looked into.
Well, thank you all very much. I know, Chantal, you've got to rush. You're a very busy girl, as always, at these meetings.
EASD works us hard.
EASD works you very hard indeed. Thank you so much.
Thank you.